So what's the prevalence of chronic pain in Scotland? Well, 1 in 5 people in Scotland suffer with chronic pain, and that's any pain that has lasted for more than 3 months. Now, I would argue that this figure is more, particularly when you look at the fact that people can present to the GP with any other condition or disease, and it's that specific condition that is listed, not the pain. How do Pain Association help people with chronic pain? We provide specialist education, training and support in the self-management of chronic pain. We have been pioneers in the field of self-management for 33 years, which has enabled us to develop a credible and effective person-centred approach to health that genuinely treats the individual as a person rather than a patient. This way of working helps to engage people in the principles of self-management and motivates them to adopt new ways of thinking based on a better understanding of their health and the options available to them, ultimately to lead a better quality life. We deliver our programmes through a combination of 5-week intensive courses and monthly group meetings. Whilst the courses are mainly for referrals from healthcare professionals, the monthly group meetings are open to people to self-refer into. The groups ensure the valuable ongoing maintenance and peer support, which facilitates ongoing learning and recognises this vital provision in an individual's pathway of care. There are no waiting lists, they are free to attend. You will not be judged and you will never be asked about your condition, unless anyone specifically wishes to share this at a meeting. How severe is chronic pain? Do people die from it? It can be severe when you are living with it day in, day out, when it impacts your life, your work, your family, socialising, often leaving you isolated, depressed and anxious. Yes, people die from it. They commit suicide, they die from overdose of prescribed medications. It has a huge impact on people's lives and their families, the carers. The majority of people who come to us in the first instance are often in the depths of despair, feeling that they're alone, not feeling believed, and come with lots of stress and anxiety. I want to say a bit at this point about the last 12 months during the COVID-19 pandemic. It goes without saying that it has had such a significant impact on so many people. We were fortunate that as a team we pulled together and switched our service to online, which actually took off better than what we could ever have anticipated. We also ensured that anyone who did not have access to online for whatever reason were contacted by phone each month to see how people were, and also send them out some handouts of the various topics discussed at the meetings. We began to see an overall increase in demand for our service. Some key figures will be highlighted throughout this film. 11 out of the 14 chronic pain services had ceased all new patient activity due to staff redeployment. This means that there were no first appointments at a chronic pain clinic for those referred, so they will remain on a waiting list. There were no virtual groups being delivered by the NHS within the pain management service, and all procedures and interventions had ceased. Our amazing team came together, adapted, embraced it, and the outcomes demonstrated for those who have accessed our service fill me with absolute delight and pride. The pandemic, challenges and the future. Looking at the principles and priorities of the remobilisation framework from the pandemic, the role of the third sector is clearly an important one, as it creates the opportunity for NHS boards and integrated joint boards to integrate the contribution and utilisation of third sector into the prioritisation of maintaining capacity for COVID-19 recovery. Working in collaboration with many of the boards, they have clearly recognised the importance of digital support and are willing to embrace a more blended model of service delivery as an integral pathway. Within such remobilisation plans, the Association appreciate that there is a need to alleviate the backlog of referrals for pain services, and after all these years, this is certainly more than ever the perfect opportunity to get self-management integrated better into primary care, so that people are offered this as an initial first step to helping people manage the pain, rather than automatically being referred to secondary care and enduring waiting lists. Findings from our most recent service user survey show many of those who would usually be considered most distant from the digital world are really enthusiastic to engage when they have the appropriate support, which is tailored to their needs. A call to action. I am pleased to report on a national level that the Scottish Government's National Advisory Group for Chronic Pain have made improving access to self-management one of the 4 priority areas going forward. If the value of self-management and reducing people's long-term reliance on specialist services and treatments which demonstrate low clinical efficacy is clear, then patients need help to be better engaged with the concept of self-management. It is appreciated that time is maybe limited to explain self-management, and it is also recognised that many people might not absorb all the details during a GP appointment, but this is maybe an example of the type of action needed within future framework around pathways, language, and a more holistic modelling approach.